I am really honored to be here today to kick off the first Southern California State of Reform. My apologies to whoever was working at 1008. It's one of the terrible things about the new age of technology. We can change things at a moment's notice. So thank you, really happy to be here to learn about what's going on in Southern California, because certainly all healthcare is local, and to share with you a little bit about what's happened a bit farther north in our state, because I think there's a lot we can all learn from each other. And we're all facing the same things. And I have tried to distill down the environment in healthcare to 2 slides. I know all of us attend presentations. We see slide after slide, trend after trend. I think I've got it down to 2. I'm trying for 1. And here is the first slide of, maybe not. Oh, there we go. Here is the first slide of healthcare. And you all know what this is. This is just simply a graph that has numbers on one side and time on the other, and it goes up. And this is rising copays, rising premiums, the increased number of policy pundits, increased number of consultants. It's the increased number of primary care homes in our community. It's the increase in codes in ICD-10 versus ICD-9. I mean, what meeting do we go to where the first slide isn't this? Something is rising. And that's the challenge that we all grope with every day. And then here's the second challenge in healthcare. This is just a scatter plot. And you've all seen them. And indeed, this is healthcare today. This is utilization trends between 50 different primary care clinics risk adjusted. It is 50 different, actually this is 50 different hospitals from the same healthcare system, their cardiovascular outcomes compared to cost over the course of 10 years. This is quality, this is healthcare clinician distribution, this is healthcare disparities, which really challenge us. I mean, in our state, the diabetes death rate for African Americans is twice that what it is for white people in our state. It's actually pretty similar here in California. And it's this graph that really challenges all of us each and every day. And we all work in very much the same environment. Healthcare costs are rising faster than any other economic indicator. They're taking precious resources from other laudable public functions, education, transportation, the arts, public safety, you name it. And healthcare outcomes aren't what we want. Our healthcare outcomes are that scattergram. And we know we can do better. And this is that first graph. Healthcare costs are expected to double over the next 10 years. We say that every 10 years. We don't think it's possible. And yet every 10 years we get surprised. You know, since 1999, we've seen premiums increase 172%. We've seen workers' contributions to premiums increase 180%. But the issue is when we compare that to inflation and to workers' earnings have only increased 47%. And inflation's been 38%. So this is an unsustainable economic model. It's unsustainable for our businesses, it's unsustainable for our governments, and it's unsustainable for our families. And if you had any doubt whether it's unsustainable for our families, this is the percent premium is of family income. And it tracks it from 2001 and predicts it out to 2021. And in 2001, it was 12%, and it was predicted to double in 10 years. And I remember sitting in rooms in 2001 and 2002, and we said it would never double. That would be catastrophic. Healthcare premiums could never be a quarter of family income. And lo and behold, 10 years later, it was 22%. And now it's predicted to be 31% in 2021. And I know we're all sitting around saying it's impossible, but we've continued to do this time and time again. So what I wanted to do with you today is to share with you a little bit about how we approached this issue of sustainability in healthcare, the issue about quality all across the board, not getting the outcomes we want in our little corner of the world. Because, traditionally, we've all done the same things. Actually, whether it's industry, whether it's government, we've done pretty much the same thing in healthcare for the last 40 years. When healthcare costs increase, we cut people from care. State Medicaid programs are very good at doing that, but actually the commercial market does it as well. When I came to our state of Oregon 25 years ago, most businesses offered full family coverage. Today they still offer it, but you have to pay $300, $400, $500 a month for the spouse and children, and that costs out a lot of workers. So people get cut from care. We cut services. We do that as states. We do that in benefit package design. We're very good at being able to cut services. And the last thing we do is cut provider rates. States are excellent at that. We've got a long history of cutting provider rates in Oregon. I know here in California, one of your big issues is the rates being paid in Medicaid programs. And the other thing we do is we shift costs. We've been shifting costs onto consumers, and we shift our costs onto the federal government. All of our states have been very good at what I call alchemy. We've been able to figure out how to create more and more federal money to bring to our states. We've done that with hospital taxes, with MCO taxes. We keep thinking we can just get more money to feed the beast. And I stand here today asking everybody, how's that worked for us? Is healthcare any less costly after 40 years of doing this? Do we have any greater quality and a system we can all be proud of? I don't think so. So we sat down and we said there's got to be a better way. We've got to think about a way, what's in essence a fourth path, a way to reduce waste, improve health, because certainly there's a lot of waste in our healthcare system, we all know that. How do we create some local accountability for health, some responsibility, align financial incentives, pay per performance and outcomes as opposed to volume, and do that last piece there, create true fiscal sustainability so we don't have to worry from budget cycle to budget cycle how that works. And we felt the way to do that was to basically change how care is delivered. So this is when everyone looks and says, what do you mean change how care is delivered? So let me tell you a story about how changing care looks like. This is Malik. And Malik's a 10-year-old boy. Now Malik's 13. But when Malik was 10, Malik was going to the hospital probably about once a month. Malik had asthma. And about once a month, Malik had an exacerbation of his asthma. He got short of breath. It was very scary. He would go to the hospital and he would get treated. And Malik had really good primary care. He would go back to his primary care doc. I'm a family doc. He would get his medicines. He would do well. And then 3, 4, 5, 6 weeks later, Malik would end up back in the hospital. Time and time again. And then Malik got enrolled in a new kind of a program where a community health worker went out to his house, trained in what precipitates asthma, worked with his family. They actually took a lot of things out of the house that were causing his asthma attacks. They bought the family one of these HEPA vacuums that takes dusts out of the apartment they were living in, taught the family better how to deal with asthma. And over the next year, Malik was never in the emergency department once. Now, that's changing how care is delivered. Why? When I practiced medicine, no one ever paid me to send a community health worker out to Malik's house. In fact, even if I wanted to, there's no code for it. They're not licensed healthcare providers. No one paid me to do that. In fact, I got paid when Malik came into the office, not when he stayed home. And the sicker Malik was, the more I got paid. And I got used to being able to, I knew the difference between a 99213 and a 99214 and a 99215. And we learned how to code for that. And that created a care system that was really different than changing care for asthmatics. Imagine if we had a healthcare system where our goal was no child should have to go to an emergency department who's got asthma. Half of our state's Medicaid populations are kids with asthma. Are kids. And so imagine if that was just one of the goals of our state's Medicaid systems. That, to me, is changing how healthcare is delivered. And we don't do that because we focus on the 10%. When we look at what makes us healthy and what keeps us healthy, and we all know this, the dirty little secret is a small piece of what keeps us healthy is the medical care we receive. It's a small piece of what keeps Malik healthy is the inhalers that he has. But a whole host of what keeps us healthy is our lifestyle and our behavior. So getting the dust and the behaviors that Malik's family did is a huge contributor to our asthma. Where you live, your zip code, huge. Malik fortunately didn't live next to a smelting plant, but imagine what it would be like for a kid with asthma living next to a smelting plant. So we've got to create a healthcare system that focuses more on the 90% than it is where we're focusing 99% of our effort on the 10%. We've got to rebalance that, and that's what we sought to do in Oregon. We brought together groups of experts, healthcare executives, doctors, hospital administrators, community members, healthcare advocates, a cast of 40, 50 people with great expertise, politicians, to sit around the table over a course of a series of months, meeting once a week, to try and figure out what that new healthcare delivery system would look like. We engaged the community. We had formal community meetings around the state. We traveled to every part of the state, listened to people, got their feedback, presented what we had come up with in this group. We built support for it. We defined the problem. We used data to show how we could really move the needle and create a better healthcare system. We communicated a lot with our legislators, with our community stakeholders, with our tribes, with the public. And this is what we came up with. We came up with what was a coordinated care model. And there's 6 ingredients to this. And they're pretty generic, and they make a lot of sense. But if you have these as the 6 foundations, I think you can do this in any community. So number 1 is the finances. You've got to have a sustainable rate of growth. That's that green circle there. How do you create a budget that grows sustainably, aligning with any other economic indicator? 2, measuring performance and outcomes. How do you have a healthcare system that focuses its effort on outcomes, not on volume? Number 3 is shared responsibility. How do you create community accountability for health? So someone is actually accountable for the dollars and for the quality. You have to have transparency about price and about performance. Otherwise, you can't be accountable. You've got to have a system that uses the best practices and best information. And you've got to change how you pay. To be able to pay for outcomes, to be able to pay to keep the Maliks out of the hospital, than to keep the Maliks in the hospital. And we did that. We took these 6 ingredients, and I think every state can do it differently, and we created coordinated care organizations. And these are new organizations to care for our Medicaid population, where the governance is really key, because the governance is the accountability piece. And what the governance is of these coordinated care organizations is a partnership, a community partnership between the major healthcare providers in the community. And that basically means a lot of the doctors and hospitals in a community, the community members themselves, and those taking financial risk. That's the partnership that we were looking for. They have strong community advisory councils and a working relationship with their local public health department. Those are the key ingredients. No longer were we looking to have the competition between doctors and hospitals, between health plans and hospitals and doctors, but how do you bring everybody around the table to understand, here's the money, here's the outcomes, how do we all share in this and have a shared stake and accountability for the health of our community? Because all healthcare is local. I mean, Tip O'Neill said all politics is local, but all healthcare is local. And how do you get all the stakeholders around the table to stop competing, and particularly to stop competing for a larger piece of the financial pie, because that only means someone else gets less, to be able to create health for a community. These organizations have one budget. We put together and integrated the funding for mental health, dental, oral health, and physical health. One budget, that's key, that this organization is accountable for. The ability to use Medicaid dollars flexibly. So the ability to start to use Medicaid dollars to actually pay for some of the social determinants of health. Housing, other kinds of things that we know help make people healthy. Our federal Medicaid laws have in the past prohibited us from doing that. A budget, not a rate, but a budget that grows at 3.4% per capita a year, so that there's a sustainable, predictable rate of growth that this coordinated care organization has to deal with. And then not just responsibility for that sustainable rate of growth, but sustainability for health and for outcomes, for making certain that people get healthier in the community. We implemented this in our Medicaid program, the Oregon Health Plan. We have 16 coordinated care organizations around the state, and they really are community organizations. They're 16. They're in communities. They really mirror the major hospital systems, the healthcare providers, the community in a local system who all get around the table. They now serve 95% of our state's Medicaid population. And we're looking to extend this into our public employees benefit and to other state purchasing. We got a waiver to do this. Everybody needs to get a waiver from the feds. It was actually, in some ways, simple. In some ways, it was difficult. Simply, the waiver did a couple of things. It established these new CCOs as our Medicaid delivery system. It allowed us to use Medicaid dollars flexibly. So we were no longer bound by the codes. We could have our CCOs pay for non-licensed healthcare providers, pay for, we have a story in our state of a 90-year-old woman who's got congestive heart failure, and it's a hot summer day, and she's living in a third-floor walk-up apartment, and gets tipped into congestive heart failure by the heat and the changes in her body, and ends up in the hospital for a week and comes home, does well. We pay for the hospital stay, but we don't pay for the $200 air conditioner to keep her out of the hospital. And that's what flexible funds are. I was just out in a rural part of our state last week talking to one of our CCOs who told me a story, it's the flip side of that, about a gentleman who had been in and out of the hospital, particularly when they looked at it during the winter, because he lived in an unheated cabin in rural Oregon. And his local coordinated care organization paid for a cord of wood. $165 for a cord of wood that heated his little cabin for the winter, and last winter, as opposed to the previous 3, he was never in the hospital. So it's really interesting what you can do when you're able to use Medicaid funds flexibly. We had a federal government investment in this, $1.9 billion. I know you guys are getting 6 or 7. We promised the feds a return on that investment. We said that we would give them a $5 billion return on that $1.9 billion investment over 5 years. And we would do that by lowering the trend rate in Medicaid from what was 5.5% per capita increase in costs down to 3.4%. And we would do that by not reducing benefits, not reducing eligibility, and we would adhere to some targets in quality metrics. We were all in. If we didn't meet those spending targets, we had penalties. We need to pay back hundreds of millions, actually $1 billion to the feds. And likewise, same thing on the quality metrics. We felt that the only way to really do this was to really walk the walk and show some real outcomes. And you think about it, 2% doesn't sound like a lot if you can reduce healthcare spending trend by just simply 2 percentage points. But when we looked at it, this is, we did some modeling across the state by what would happen if we took all of our state's healthcare purchasing, Medicaid, which we purchase, public employees, which we purchase, our health insurance exchange, and we lowered trend by 2 percentage points. It creates an incredible amount of revenue for the state. Those are thousands of millions of dollars, which translate into billions of dollars. And so we were looking at billions of dollars every biennial budget cycle to be able to reinvest in our state. Our CCOs are also accountable for 33 quality metrics, and the results are reported publicly every quarter, as well as their financial data. So we had, before we had these CCOs, we had very fragmented care. Now we've got more coordinated care. We've got a ways to go. We had very disconnected funding streams. Now we've got a global budget. Before we saw mental health organizations who managed mental health care but weren't aware that some of their clients were in the emergency department once a week. We had unsustainable growth in our finances. Now we've got something which is sustainable. If we can hold our state's healthcare costs at 3.4%, that's in line with every other state economic indicator over the next 2 decades. We used to have limits on services before. We would limit services to people. Now there's no limit on services. In fact, there's a way to better flexibly use services. We had a healthcare system which was very disconnected from population health, and now a healthcare system which is amazingly connected. My trip around the state the other day where I learned about the cord of wood, I also sat down with a group of rural, salt-of-the-earth family docs from a very politically conservative part of our state. And we talked, and I counted 5 docs. They mentioned the word social determinants of health 17 times in an hour. I'd never been in a meeting in that part of the state where I'd heard that. I hear that a lot when I go to Portlandia, but not when I go elsewhere. There used to be a limited community voice in our healthcare system. There's now a much greater voice, still needs to be greater. So what have we been seeing? One, every CCO is living within their global budget. The state is meeting its commitment to reduce Medicaid spending by 2%. We've got progress. One of our goals was to reduce health disparities. We've got a long way to go in that, but we're beginning to publish some data about that, and I'll show you that. And we know that progress is not going to be linear, but the results we're seeing are encouraging. And here's the results. Emergency department utilization, from the year before we started CCOs to after, down 21%. And let me tell you a story about that. We, like you, are heavily Medicaid managed care state. So that's down 21% from the same Medicaid managed care plans that I sat around the table from and used to say, Bruce, there's no fat in the system. We've done everything possible. We can't do anything anymore. We need more money. And that was the year before CCOs. 2 years after CCOs, emergency department utilization for the Medicaid population down 21%. Primary care visits up 18%. The issue isn't lowering everything, it's making some investments, and clearly these CCOs have made big investments in patient-centered primary care. Adult hospitalizations for asthma down 39%, for chronic lung disease down 48%, for heart failure down 34%, short-term complications of diabetes down 9%. The growth of patient-centered primary care homes has been astronomical, partly as a strategy to get at a lot of what we're looking to get at. Developmental screening for children up 68%. It's amazing what can happen when you publish on a regular basis people's performance and you pay them for it. When we started this, 1% of the CCO budget was for quality. Every year that increases a percentage point. So an increasing amount of dollars that go to these CCOs is going to be based on quality. It's a busy slide, and don't look at the details, but this is what gets published quarterly. On the left-hand side are 16 CCOs, and on the right-hand side, this is their emergency department utilization. The silver was their baseline, and the other colors are where we want to see them move, out to the left of that line down the middle, which is the benchmark. Once everybody is on the left side of the benchmark, we'll switch to another metric. This is congestive heart failure admission rate. This, rather than being by CCOs, is actually by race and ethnicity. And so we look at this every quarter, publish it, and hopefully incent communities to take a look at this data and do better. And what we're seeing for the first time is people have something to collaborate around. We used to have communities where there was tremendous competition between every segment of our healthcare system. Healthcare is an incredibly competitive environment. You guys all know that better than I do. This created a new table where people were now collaborators. They shared ownership and governance in this new organization, and they had a stake in its outcome. And that created a really dramatic new environment in many of our communities. We had to make some investments in this, not a lot, but this can't be done without things like some help and support for changing how care is delivered. We created a transformation center, 16 innovator agents around the state, sort of like health extension agents, learning collaboratives, peer-to-peer learning systems, huge investments in non-traditional healthcare workers. You can't throw a stone in our state without hitting at least 3 or 4 community healthcare workers. They're in primary care offices, they're in emergency departments, they're out in communities, they're everywhere. Each CCO has to submit a transformation plan, a lot of help and support for primary care homes. And the better value comes from local communities innovating, figuring out how to do this better. Focusing on chronic disease management, on comprehensive primary care, looking at how to integrate behavioral health and physical health. We got a long way to go in that. Creating alternate payment methodologies for their providers in their community. Investments in telehealth, new care teams, use of best practices. These are all the ways they're meeting those metrics. The next step in Oregon is to align these models with all estate purchasing and to leverage this work to reduce costs across the state, because in our state we all use the same healthcare systems. So let me close by just going through a few of the challenges and some lessons learned, and then open it up for questions. So, challenges. There's a lot. And probably the biggest challenge is time, resources, and expectations. We all expect things to happen very, very quickly in this new world. I think it was Senator Daniel Patrick Moynihan that said, you shouldn't be involved in social policy if you don't have 30 years to devote to it. The arc of change can be sometimes frustratingly slow, and time, resources, and expectations are tough. Change is hard. In fact, change is very, very, very hard. And it's hard. Doctors and hospitals in our communities learned how to code. In the 90s, we learned how to maximize that coding, and now changing from that method of payment is really hard. Behavioral health, dental health integration, oral health integration, lot of challenges in that. That's could be a whole day's talk. Ensuring robust provider networks to meet client needs. Big issue. The issue isn't adding more and more providers into a system. It's how do we create capacity in a system by making care more transparent, more efficient, more home-based care. How do we transform care and pay for outcomes? How do we account for those flexible services? There is no code for a cord of wood. And how do you account for that? How do you account for it on a number of bases so that the public has some trust in what you're doing and using Medicaid funding so that you can start to track some of the outcomes from some of your community interventions? It's tough. Actuarial soundness, that is a huge challenge. We have a system that embeds the last year's inefficiencies and trends them forward. And how do we move beyond something like that? Challenge for us has been we were under the gun, penalties if we didn't lower costs and improve care. Training using new healthcare workers. So we have hundreds of community healthcare workers in the state now, but creating the training programs for them, huge challenge. And what constitutes an appropriate training for a non-traditional, non-licensed community healthcare worker? Increasing consumer engagement. This isn't just shared responsibility amongst healthcare providers and insurers. How do you really, in a meaningful way, create shared responsibility for health with consumers? I don't think anybody has tackled that yet anywhere around issues of lifestyle, obesity, smoking. Huge issue and a huge challenge for all of us. The ability to exchange health information in a community. We try and create these local community coordinated care organizations that are all aspects of the community, and they all have a different health record. How do they share that? How do we integrate with the other social systems that have a huge impact on health? As I said, much of Medicaid are kids. How do we meaningfully integrate our Medicaid programs with early childhood learning programs and with the education system that has as much to do with child success as we do in the healthcare system? So we learned a lot, and we continue to learn. And here are a few of the lessons. One, you got to have a common vision. Unless everybody is rowing in the same direction, you're going to have a scattergram. So key to this is having a common vision. And then you've got to garner support around that vision. There has to be legislative buy-in from your political leaders. There needs to be stakeholder buy-in from your community leaders. And they have to have a shared commitment to health reform. If you don't have that common vision and that common buy-in, you're dead in the water, because we all know how quickly anybody, it's really easy, as a lot of people in the policy world here, it's a lot easier to kill legislation or to kill something than it is to grow something. So you've got to have a common vision, you've got to have commitment, you've got to engage consumers, you've got to engage the healthcare system, you've got to engage CMS, and that's a lot of work. That means a lot. I met monthly with our CCO executives, with legislators. How do you continue to garner that political buy-in? Don't underestimate the investment needed in change management. We all think we can just tell people to change and they'll change. But you've got to have a strategy and a huge investment in change management. We didn't do that. And, in retrospect, a huge lesson learned. Having reliable data and information is critical. And it has to be data and information that people have some trust in. It isn't just my data. It's my data. It's actually our data. If you come to the table with data and information, people have to have some confidence in it. If they don't, you're dead in the water. There needs to be a structure and leadership with clear accountabilities, whether that's for a community or a state, to change the healthcare system. Without that structure, without that accountability, without that plan, without that vision, without that buy-in, without that structure, it's not going to happen. With that said, there's no perfect structure. If you're looking to restructure an entire county's healthcare delivery system, that may look really different than an entire state system. If you're looking to restructure Medicaid, that structure looks really different. But regardless of what structure you use, government agencies are key in this, whether they be state agencies, whether they be local county agencies, and the work of those agencies has to be restructured. It has to be about health reform. That has to be their primary job, not their secondary job. That was a huge issue for us in our state, where many people felt that their job was particular to regulating Medicaid, as opposed to being switched to how our jobs as state agencies is actually to promote health reform. It takes a village. It really does take a village. And I don't say that lightly. There needs to be broad community support, and communication is key. I don't think it's possible to communicate enough about all of this. It's enormously complicated. We all talk in very different languages. We all say things, we nod our heads, we think we're in agreement, we come back the next day and we find out there's huge gaps between us. This takes a lot of time and a lot of investment. It's hard work. We also learned you can't use that as an excuse to slow down. To say that it's hard and to say that it's going to take time takes the wind out of your sails. You've got to move forward. We've got a really dynamic marketplace, and we've got to all take advantage of that. Financial support helps, and this is the key piece. Getting dollars from the feds or whoever really helps, but you got to use those dollars strategically. If you're just going to take dollars, and this is what we learned, if you're going to just take dollars and invest them in increasing the payment rates in your old system, that may not be as strategic as taking those dollars and investing them in how you transition to a new care system. So, as an example, in our state, how do we begin to take dollars and start to invest them in our hospitals so they have some ability to not suffer financially when we reduce, all those reduced asthma and CHF admissions is lost revenue. So how do you strategically begin to take dollars and invest them in transitions so we can transition from an old system into a new system, instead of taking that financial support and investing it in just propping up the old system? So financial support is key. You need some money to do this, but it's how you use that money, whether it's to get back to, you're going to use it to prop up benefits, rates, and eligibility, or you're going to use those dollars to create something remarkably new and different that you can be proud of. So, I think our biggest lesson was you can do this, that, the future does indeed belong to those who create it. And it's been really fun to go around the country and see that every state is doing some of this. That the biggest thing over the last couple of years has been, this renewed focus on state health policy and on state health reform. That's where the action is. And we can do this. We can all learn from each other. Thanks for having me here today. And I think we got time for a couple questions.
Dr. Goldberg.
And if you don't ask one, DJ will. I know that from experience.
Dr. Goldberg, thank you. We do have a couple of microphones here, and if you have a question, just go ahead and raise your hand. This is a shy group in California, Dr. Goldberg.
Yeah, I'm surprised.
Let me ask you this question. How have you seen the migration of hospitals from thinking about putting heads in beds to thinking about keeping heads out of beds as a way to drive a bottom line P&L?
I see I see a lot of interest and a lot of understanding that that's going to be the way to do this in the future. And I actually see a lot of our hospital executives thinking about and understanding that it's going to be a new model. I think the issue is how we get there. And I think one of the frustrating things is it gets back to that common vision thing. If we all if a community has 6 different visions for how to get there, that can be really difficult. So I think we've got a long way to go in how we create the structures and systems to support that. I'm really buoyed by the fact that there's a lot of talk about it, and I think a lot of interest in it, although a lot of concern that we just don't know how to do it. And the other big concern, and it's, there's this Yogi Berra quote that just went out of my mind.
90%. Is this the 90% is mental?
No, that'd be a good one. But it was something about the other team. If the other team wins, it could be problems for us, something like that. And the other issue is, is the federal government. As all of us as states are going in one direction, and we have Medicare as this huge payer, how do we sort of reconcile that? And I think it's a huge issue for our hospitals.
Yeah. Question over here.
Good morning, Bruce. Nicky Fantides from San Diego. Congrats for what you've accomplished to be able to bend the cost curve and address disparities at the same time is as close to a near ideal scenario as possible. But it was interesting because my question was exactly about what you just referenced in your last sentence. Has there been any intentional consideration of possibly looking at including the Medicare population into this model somehow, knowing that ultimately the feds were involved in providing the waiver?
That's been our holy grail. Because this is all based on all healthcare is local, and policy needs to align. And it's always been our vision and our dream that we could do that. In fact, our good Senator Wyden, included in the Affordable Care Act the opportunity for 1132 waivers down the road, which hopefully will allow states to do that. Whether that will ever happen, I don't know. Our state would love it to, but the politics are really, really difficult around that, and particularly it's a different politic. It's not the local politics of providers, it's the national politics of Medicare, and I think a lot of senior advocates around the country very concerned about different benefit packages and different ways states will deal with what's been a unified benefit for seniors. So I think it's going to be a tough haul. We'd love to do it, and I think there's some ways to provide some of the assurances that care for Medicare beneficiaries will only get better, not worse. But I think there's always a fear that when people get Medicare dollars, when states get Medicare dollars, they're going to resort to the first 3 tools. They're going to cut people, cut payment, or cut benefits. And that's been a real concern. So it takes a long time to build the trust to be able to show that you can't do that. But I think for states to be successful, you got to bring Medicare into it.
I think we have a question back here. Is that right? And then I want to go to back here, and then we'll let you go, Dr. Goldberg.
Good morning, Damian Bean from Pacific Dental. So I am a huge believer, I think it's brilliant with the root cause analysis. So the $165 cord of wood. Where does personal responsibility end, and how are you going to manage that on a go-forward basis? Because it's not $165 when you add the delivery mechanism and the analysis and the incentive behind that. So I'm interested in how you're looking at that going forward.
It's a great question. This whole issue of shared responsibility for health is a real enigma, I think, to a lot of us. How do we engage people in a way that they're engaged, and how do we create an array of so to speak, the right policy across our community that's a mix of incentives, disincentives, et cetera. And I liken it to smoking. When I did my residency many decades ago, it was in a tobacco state in North Carolina. And I remember the patient carts that went around, sold cigarettes, and people smoked in their rooms. And that was in 1980. And when you think about it, we've had a dramatic sea change. And I was just back there. And even in a tobacco state, there's a cultural change about smoking. And we've done that with an array of public policy, incentives, disincentives, shame, taxes, no smoking in restaurants, education, you name it. We've used a multitude of tools, but it took a long time. We still have 19% of people in our state who smoke, and probably the same here. So it's a long way of saying I think it's going to take us a long time to develop that shared responsibility. I don't think there's going to be one answer. I think it's going to be a patchwork of ways that we do that. And, I was very happy recently to just see, if you've seen what's happened to Coca-Cola and Pepsi, the amount of sweetened beverages that people drink has dropped dramatically. And that hasn't happened by accident. And so we can do this.
We're short on time, but go ahead, quick question and quick answer.
Okay.
I was hoping you wouldn't say quick. I'm still trying to formulate this question. I think we in healthcare are caught between a rock and a hard place. I think we've known for a while that preventive care is really where we need to go. But unfortunately, we're paid for dealing with people when they're sick. So we're getting a mixed message from the people who hold the checkbooks. I mean, a great example, one of the largest long-term care organizations in the country just fell under scrutiny and is getting penalties because they are doing rehab services for senior citizens. Even though survey after survey, study after study says if you treat long-term care people with active rehab services before they get sick or before they fall, they cost you less. So now we're getting mixed messages. You're penalizing us when we do preventive care. You want us to treat them when they're sick, but you want us to reduce costs. My question is, how do we start influence those people who are paying us to come face to face with the reality of what the health system needs to be?
I think it's a great question. The short answer is I think that has to be done locally. And the more you have local communities involved in payment and reimbursement, and they determine what's going to fit for their community and their population, and you're held to a budget, I think you can do this. When decisions are made 2,000 miles away, I think it's hard. And when there isn't shared responsibility and shared accountability locally, I think it's really hard. So that's my short answer, but it's a great discussion.
Dr. Goldberg, are you sticking around for a little while?
Yeah.
So feel free to ask him even more questions. Thank you for your time and for coming down, Dr.
Great.
Goldberg.
Thanks,
Appreciate
DJ.
it.
Appreciate it.